Hi, everyone, and welcome back to the #C Arthritis event at this year's Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting held in Calgary. We're so excited to be here today with you. My name is Cheryl Koehn. I'm a person living with RA, rheumatoid arthritis. I work for Arthritis Consumer Experts, and we host through the Arthritis Broadcast Network this event. And right now, we are so happy to have Dr. Arielle Mendel sitting with us. Welcome to the studio, Dr. Mendel.
Thank you very much for having me.
Yeah, it's exciting. I'm going to tell the audience before we dive in a little bit about you, Dr. Mendel. So Dr. Mendel is an assistant professor in the Division of Rheumatology at McGill University, so situated in Montreal. La Belle Provence, I should say. Her research focuses on patient safety in systemic autoimmune rheumatic disease. So this is a topic near and dear to most patients' heart is our safety when we're taking medications. Dr. Mendel aims to improve medication safety in this population, meaning people living with an autoimmune form of arthritis, by studying the root causes of adverse drug events, with a particular focus on glucocorticoids, prednisone, as an example, and other immunosuppressive agents to design innovative ways to improve medication safety in people living with these diseases. So first and foremost, everybody in the audience already loves you because it sounds like you're super focused on the safety, our personal safety as patients while we're taking medication. So super keen to jump right in. So welcome again. Dr. Mendel, you gave a podium presentation. So first of all, congratulations. Not everyone gets one of those, and you actually have to submit your proposed talk and it's judged. And so hearty congratulations. The title of your podium presentation was Comparative Safety and Effectiveness of Biosimilar and Originator Rituximab. Otherwise, patients know it as Rituxan, but the generic name we'll refer to it as now because there are different people making it, different companies, rituximab, for induction or maintenance in ANCA-associated vasculitis. So you're going to talk about 6 months worth of results in this population of patients. So, okay, first of all, just tell us really quickly before you get into the meat of what that talk was all about. How do you fit into rheumatology? What got you into it? I look at you and I see just young superstar written all over you.
Oh, goodness me. I've actually wanted to do rheumatology since I was in my first year of medical school. I had never heard of that condition, that group of conditions before medical school, but I went to medical school in London, Ontario, and the rheumatologists there were really inspiring. And I think it's sort of like how everybody chooses their career to an extent. The more you get exposed to it, the more you are interested in it and love
Yeah.
it. So it was through what we call observerships during medical school, where you go and you hang out in the clinic, in the rheumatology clinic, but also the Canadian Rheumatology Association summer program opportunities, where I also met other rheumatologists and research that I did also during the summers when I was an undergrad and also, during medical school that kind of made me decide, well, this is what I want to do. So then all through the rest of my medical training, I always knew I wanted to be a rheumatologist. Nowadays, I'm pretty focused in kind of two big categories of autoimmune conditions that can be associated with arthritis. So one is vasculitis, which is inflammation of small blood vessels, but those conditions can cause arthritis in about 30%, if we're talking about ANCA-associated vasculitis. And then also, I see a lot of lupus and related conditions. And so those conditions definitely cause a lot of arthritis. And so that's sort of something I became interested in more towards the end of my rheumatology training. I did extra fellowship training in vasculitis in Toronto. And so that's how I got into this.
It's funny, it takes a village, hey, and people, it's about people. And so you were inspired by the folks in London. also through your training program. So it's not dissimilar from other professions, actually. You meet someone in that profession on your way up or being exposed to it, and they get you super excited. Well, we're thrilled that you came into rheumatology and are now giving talks of this caliber. Tell us about the podium presentation now. Dig into that a little bit more for us, because safety in meds is probably the number one thing you talk to your own patients about. The first thing that we comes out of our mouth is, well, is it if, is it going to work? And
Mhm.
and is it going to be safe in me, doc? And is it hard to take? And there's just some really fundamental questions, and a lot of them pivot around safety. So tell us about the talk.
Okay. So to start with, maybe I'll just talk a little bit about rituximab. So you
Sure.
mentioned that it's a biologic drug. It's one of the first biologic drugs that was actually available to treat rheumatoid arthritis. So it's been around for, a long time. In 2010, which is already now 15 years ago, this drug was studied for the first time in a trial of a different condition, not rheumatoid arthritis, but ANCA-associated vasculitis, which is much more rare than RA, but has also very limited treatment options. So to this day, rituximab is actually one of the only drugs we have that work in this condition, believe it or not.
Yeah.
So, unlike rheumatoid arthritis and some other types of inflammatory arthritis, where the number of different biologic drugs has really exploded over the years, we really are mostly using rituximab. And you mentioned Rituxan a little bit earlier. So, that's kind of like Kleenex for
The brand name. Yeah.
exactly. So it's the original brand name of the originator biologic drug that was first available and first studied in rheumatoid arthritis and other conditions as well. Um, but then after the patent expires for those drugs, then other companies can come in and they can make what's called a biosimilar. So sometimes when I talk to patients, I sort of describe this as similar to a generic drug, but it's not quite the same as a real generic drug because these are really complicated molecules that work in our body that interact with our cells. And so because these drugs are so complex, we don't really use the word generic, but essentially it's that idea where it's supposed to be very, very similar to the originator molecule, but there's some things that have been changed about it because they don't have, the original recipe
Yeah.
that the company that made rituximab made. And
Yeah.
so when the biosimilars of rituximab came out, they were studied in randomized trials for rheumatoid arthritis to make sure that it works just as well in RA as it does as the originator did. But they did not do this for ANCA-associated vasculitis because ANCA vasculitis is extremely rare,
Yeah.
and they kind of assumed that the safety and effectiveness, if it was good enough for RA, it would be the same sort of idea for ANCA-associated vasculitis. But what we don't really know is this drug really acting in the same way to fix the problem of this condition as it does in RA? So we don't really know if it can be translated to another condition. Because, clinical trials in vasculitis take decades to perform, we didn't want to do a randomized control trial. But we had this sort of convenient thing where across Canada in 2020, all of the payers, like the governments and the private insurances, started only reimbursing biosimilars. And that is the case for many biosimilar
Right.
biologics that are used in rheumatoid arthritis as well. And so we collected information on people with ANCA-associated vasculitis who had received the originator, back in the day when it was available from 2018 to 2020. And then we also, looked at people who were still getting the originator even after the availability of biosimilars. And we also looked at people who started straight up for the first time. They were treated with a biosimilar for the treatment of their vasculitis. And then we also looked at people who switched from They were already very stable on the originator rituximab, and usually people continue on this drug for several years.
Okay.
Um, and it's an every 6 month IV treatment. Just I should have said that at the beginning.
That's okay. I
Um,
think some
and
people who are watching are familiar with the dosing regimen, but it's good to mention it anyway.
yeah,
Yeah,
so so that there was a small group of people who we followed after they switched from the originator to biosimilar because many patients are worried when they're told you have to switch because your insurance won't reimburse you anymore, won't pay for the originator anymore. Many people are worried that they might flare. And flares of ANCA-associated vasculitis can land you in hospital,
mm,
and they could even be life-threatening. So it's a pretty important question for patients. Um, and what I'm really proud of with this project is we were able to collect data on 200 patients with this condition. And like I said, it's pretty rare. There's maybe 20 new cases per million population per year that come. So it's hard to always include all these folks into studies. And we had participation from 9 different centers across Canada. And the long and the short of it is, when we compared people who got the originator to people who got the biosimilar to treat the same condition, we didn't see big differences in how well people got into remission with their condition. And we also didn't see big differences in, you mentioned safety. So when we think about safety, the things we measured in this study were what we call serious adverse events. So those are things that land people in hospital. They've made people very sick. And the majority of the time in this condition, we're talking about infections
right,
because rituximab is an immunosuppressant, and people with ANCA-associated vasculitis tend to get infections. Up to a quarter of people in the first year of their treatment will have a serious infection.
right.
So we looked at that too. And, based on the information we have just at 6 months follow-up now, we don't see any differences in the safety or the effectiveness. That being said, it takes a little bit of time in this condition to observe relapses after you've gone through your induction. So our primary interest is whether people have more relapses in the group who got the biosimilars, and we're following everybody for a total of 24 months. So it's gonna take a little bit more time before we have enough follow-up to really, say more definitively
Right.
what we think is going on. But based on what we've seen with other conditions like rheumatoid arthritis, and that was a randomized trial, I don't think we're going to end up seeing differences in safety or effectiveness. But I think for people with this rare condition who might have gone through, a very serious hospitalization at the beginning of their treatment, they might have been on dialysis. I think it's very reassuring for them to know that, they're getting a drug now that's going to work just as well as the one before that was available, just because there's so few drugs out there to treat this condition.
Yeah, that's amazing. And I think, one of the ways we try to explain to the people that come to us looking for research-based information, Dr. Mendel, is, biosimilars, while they can never, because they come from a living cell, be exact copies of the originator, what is almost identical are the outcomes in patients. So,
Yeah.
when you look through a microscope, there's slight differences, but when you look at a table that shows what's happening good and bad to people who are receiving the therapy, the results are pretty much the same. And biosimilars, the reason for these switching policies by payers is because they're significantly less expensive. And this all happens after the originator brand has a chance to recoup its investment through patent. So this is really amazing work, and that is a very robust number of people to have in a trial with such a rare uh, disease, is it not?
Yeah, so just to clarify, it wasn't a trial the way we think about a randomized controlled
Yeah,
trial. It
yeah.
was what we call an observational study. So
Okay,
the cool thing about this is we basically followed people in their usual care, the way that they would normally be getting follow-up with their doctors. And so, if they're seen every 6 months by their doctor, every 6 months, the investigator would record information, after the patient consented to be part of the study, to see, have they had a relapse? So have they had a rise in their disease activity in the last 6 months? Have we had to change their treatment? Have we had to add a treatment?
Right.
Have they been hospitalized? Have they had another, severe outcome? And so this is how we collected the data. It's also thanks to the fact that a lot of these centers had pre-existing cohorts, so patients participating in research already, that we were able to then, include these people and, reconsent them to
I
be part
see.
of our study. They were already kind of there. And that's how we ended up getting a lot of participants who'd been exposed to originator rituximab, in
That's
the
amazing.
past.
That's amazing work. Would you consider this real world data? When you say observational, is that sort of the same? Are those terms interchangeable a bit?
Yeah, I would
Yeah,
say that.
yeah,
Real world data includes also data that researchers get from administrative data sets. So that's looking at billing information at a big province level or a big country level. This is more of observational data that's a little bit more granular. So you have the doctor, actually assessing the disease activity and seeing if there was a relapse. So you can kind of directly see things, as opposed to real world data that we get from administrative data, where you basically can just see hospitalization
right,
codes and
right.
discharge diagnoses.
So this sounds like more hands-on people data, not abstract database data.
Well, and one thing that I regret a little bit is we didn't have any patient questionnaires. We didn't collect information directly from patients on how they were feeling. So what the study, a limitation of it is it doesn't capture the very subtle, potential changes in fatigue that they might be experiencing,
Right.
that might be different, between the originator and biosimilar. So we can't capture those things. We didn't, because, we couldn't go back in time to have those questionnaires filled out by the people who got the originator, prior to us starting the study. But that's something to keep in mind, that, we didn't assess every possible outcome or every possible patient important outcome, in this research. So
Okay.
it definitely leaves some things to look at in the future.
Oh, that's terrific. I think, yeah, there's always more questions. There's always more data that can be collected, most definitely. And I think patients are really eager to provide that data too.
For sure.
I personally, as a patient, I really want to fill out those questionnaires because I know that when you get those in greater numbers, it helps you guide treatment, like clinical gestalt or whatever you want to call it. It helps you better understand in general what the patient experience is. When you think about then, if we turn to your poster presentation, Dr. Mendel, um, again, some of these words are probably unfamiliar to our lay or public audience, people with arthritis, maybe not, but you looked at the value and appropriateness of inpatient anti-nuclear antibody testing at a tertiary hospital. So let's break that down. What is an anti-nuclear antibody test?
That's a very good question. I don't even know if even the best experts really know exactly the significance of what we
Okay,
call ANA, anti-nuclear antibody.
okay,
Um, Researchers and clinicians have discovered that there's antibodies that target cellular antigens. So if you think about autoimmunity, it's your own body attacking itself in a
right,
way. And in conditions like lupus, we observe this thing called ANA, anti-nuclear antibody, which just basically means that your body has formed antibodies, which we normally have to fight infection, against little proteins inside a cell. Those are not supposed to be there. Now, saying anti-nuclear antibody is not specific
yeah,
whatsoever.
okay,
There's many different types of antibodies within that umbrella term. Um, but, especially before we discovered all of those individual antibodies, one way that people screened for conditions like lupus, if they were suspecting it, is to check for the presence of anti-nuclear antibody.
Okay.
And if it's not there, then the chances that you have lupus are exceedingly low, practically none. Okay. Um, but if then you did discover that somebody had an anti-nuclear antibody floating around, that might make you think, well, maybe I need to pursue this diagnosis further and do more evaluation. It doesn't mean that it's a diagnostic test for lupus. It's a screening test. So you can have many different reasons for having a positive ANA. And that's actually part of the reason we did this project. So there's two things. So this is totally switching gears to a totally different type of work. And in fact, this is a project that my summer student named Miga did last summer. So she couldn't come to the meeting, which is why I presented the poster,
Okay.
but it's really her work. And um, the reason we wanted to look at the question of ANA testing in inpatients, so that's patients who are hospitalized, is that we've noticed a couple of problems at our center at McGill, at the McGill University Health Center. Um, you know, one thing is that at our center, it takes a little bit longer than we'd like for getting these anti-nuclear antibody tests back. So we'd order it for a patient, and then we might not get the answer of whether it's positive or negative for a couple of weeks, or even during the pandemic, a couple of months. Okay. Um, and so this is a problem if you have a person who's very sick in hospital, you're wondering if they might have lupus or another condition where you'd want to look for the presence of ANA, but you're not getting the result back in time. So sometimes the reason why tests take a long time is that there's a bottleneck effect where there's too many tests being ordered. And so it's taking a lot of time to process all the tests and to give you the results.
Right.
Um, and so, the other thing that we, always wonder about is, are we ordering tests that are high value in our patients? And this goes for any test that we order on anybody. So, we now know we aren't supposed to order x-rays of the back for low back pain unless there's certain other things that are present with that. So you'd call an x-ray for low back pain with no other concerning features a low value test. Okay. And so one concern is that maybe people are ordering anti-nuclear antibodies without a need to order them,
Right.
especially in hospitalized patients, which could clog the system and delay testing for people who actually need it. So the other thing that we were interested in is sometimes when people are sick, for another reason, like they have an infection, maybe they end up having a positive antibody, that's not really meaningful. Maybe we'll end up finding that we have a lot of positive ANAs that don't mean anything. And so that's kind of what we found. So Miga took a random sample of 50 people who got an inpatient ANA tested. So that means they were hospitalized. They might have been hospitalized with pneumonia or with another problem. And for some reason, the doctor decided to order this ANA test. And what she looked at was, what was the reason for the test being ordered? Was there a clinical indication? Was there a symptom that made somebody think about lupus or something similar? And then, how many of those ANA tests came back positive? And also, if you followed people after their hospitalization, did any of them actually end up developing lupus or being diagnosed with lupus? Because we already know, this is well established that ANA is not specific. So
Right.
many people could be walking around with a positive ANA. Think about 8% of healthy people, and they'll never develop lupus. And so, the other concern as a patient that you might have is getting kind of a false positive test and then having that anxiety hanging over you of what does this mean?
Yeah, it's very important to consider the two words value and appropriateness, and you don't just look at those from the health system perspective. You have to look at them from the patient's perspective. Am I gaining any value from knowing this information? What value does that bring to me? And is it even appropriate? As you say, 8% of the healthy population might go on to develop lupus, but the other 92% are going to be walking around worried. You know what I mean? Like there's an appropriateness factor from the patient perspective, there is no reason to alarm people unless you're fairly certain that it's actually going to add value in terms of how you approach their health care or your prescribing or whatever it may be. So that's what I think is really interesting about value and appropriateness, those words in this poster title. So huge congrats to your colleague.
Yeah, well, and the bottom line I'll say from our work is that, what we can say is on average, if somebody orders an ANA test on an inpatient at our hospital, about 75% of those ANAs are going to be positive, um, which is very high. Um, if we say that 8% of healthy people have a positive ANA when they're walking around, 75% is very high. Now, we followed those people, during their hospitalization and after discharge. And, although it's a small sample, none of those people were diagnosed with lupus or an autoimmune condition, which means that, a lot of those ANA tests, there might have been a good intention for ordering them, but it seems like most of them don't mean very much.
Yeah.
Now, we didn't consider all of that testing inappropriate because you could have had really a true mimic of a condition like lupus, and you wanted to see, you wanted to test the ANA for that reason. But what we found is that about a third of people who had this ANA tested had already been tested for this in the past at our own center. And you don't ever need to check it again after it's already been checked. It kind of stays positive, and very rarely does it go from negative to positive with a meaningful significance. And about half of those 30% had actually had an ANA test in the prior year. So
Wow.
it means that we're repeating tests that don't need to be repeated. And if we cut out those repeat tests that are unnecessary, that cost the patient another blood poke, for example, in hospital, then perhaps we could unclog the system and make the appropriate ANA tests come back a little bit more quickly.
Yeah.
And so this is
Yeah.
kind of a first step to identifying, well, how can we fix our system a little bit, our way of ordering tests?
Dr. Mendel, is this test part of what is a much broader campaign in healthcare today called Choosing Wisely? Is this one of those tests?
Yeah, so the Canadian Rheumatology Association has a choosing wisely recommendation not to order an ANA test in somebody without signs or symptoms of lupus.
Okay.
And so that's kind of maybe where some of this started with. And also the CADITH, it used to be called CADITH, but now it's called the Canadian Drug Agency, has recommended intervals for repeating tests like ANA. When I said basically it never needs to be repeated, some people really want to repeat it. And so the Canadian Drug Agency said, well, if it's negative, you could repeat it in 4 years. And if it's positive, sorry, I reversed that. If it's negative, you could repeat it in 2 years. And if it's positive, well, you could repeat it again in 4 years.
Yeah.
But you definitely don't need to repeat it in 1 year. And so, but this is not just the only thing that the Canadian Drug Agency is looking at. They're looking at how often we
Oh, they're
repeat
looking at
thyroid tests
everything. Yeah.
and diabetes tests, because there's a lot of tests that we order very frequently that we don't need to order as frequently.
Right. And I think for the public, Dr. Mendel, one of the things we need to know about and remember is it's not about denying someone a test. It's actually about making sure that the right person at the right time gets the test. And we spend the money on that test as a healthcare system, as a society, that then is going to lead to a very important decision around their treatment.
For
Um,
sure.
and I think little is known about this. I think the Choosing Wisely campaign within health professional associations should have a public facing piece so that we as taxpayers understand, why a test gets ordered or why a test doesn't get ordered. In our own community, we have so many members saying, well, why can't I get another x-ray? Well, because we have a lineup of people wanting x-rays and very few of them are going to actually lead to a decision around what might be ailing you. So
Mhm.
I love this discussion. I think the value and appropriateness piece around choosing which tests to run and when, or if at all, is very, very important. And we can think of that in line with the theme of this year's meeting, as one of the peaks of innovation. Actually, the choosing wisely piece in everything we do, both from a physician side and a patient side, I think is super value driven and appropriateness driven. When you think of the things that you're working on in your own center, your own body of work, the work that you're helping support from your students, your trainees, what is it that you think is what are the areas of promise? What are you looking out on the horizon at these days?
Oh, that's a good question. I keep saying that, but it is. Um, what am I excited about going forward? Well, what I've become interested in, and a lot of us at McGill are interested in this, but I'm kind of maybe spearheading this from the rheumatology perspective, is also aligned with medication safety. And specifically, one thing that Choosing Wisely is interested in, and we're interested in is the idea of deprescribing. And this is a sort of a maybe people aren't familiar with this idea, but it's the idea that, many people end up accumulating medications over the course of their life. And, maybe by the time you're 70 or 80, you have 10 or 15 medications. And what people have found already is that the more medications you have, the more likely you are to have an adverse drug event, which could be a fall, it could be a hospital stay, it could be episodes of confusion, things like that. Um, and there's kind of two different areas of deprescribing that you could think about in rheumatology. One of them I'm not working on so much. It's actually Dr. Hazelwood in Alberta who's doing some work in this, but understanding how do we discontinue biologic drugs, or can we discontinue? How do we guide patients with decision making regarding discontinuing immunosuppressive medications? Because that's a form of deprescribing. If you've been on a biologic drug for 10 years, a patient might ask, Doc, do I still need to be on this drug? Or could I try tapering it and see what happens? Um, the type of deprescribing I'm interested in is regular everyday medications that my patients end up getting stuck on, that I'm not sure is helping them. So drugs to treat fibromyalgia, different drugs to treat pain. Um, Sometimes these drugs are lifesavers for people. But unfortunately, all of those types of drugs have a lot of risk of side effects, especially in older adults. And if the drug isn't helping you, or if we're not sure if it's helping you, um, one thing to consider in an older adult, especially, is trying to see if we can reduce the dose.
Right.
The other thing is that sometimes people stay on a drug, an unrelated drug, maybe it's a medication for acid reflux, and they don't even know why they're on it. They don't remember being started on it. They've been on it for 10 years. They have no idea why they're taking it. And patients that I talk to, they really want to be on less medications.
Yeah, no one this jumps up and down when they get a prescription. No one that I know.
Yeah.
Yeah.
And so, you know, something that I'm interested in doing into the future, and we're hoping to start this project in the next few months actually, is to use a tool that my colleague developed called MedSafer, which looks at all the medications somebody's taking and, has a look to see, is there any medication on this list that might be dangerous and that might need to have the dose adjusted based on your kidney function, based on your age, or perhaps even considering, having a conversation about deprescribing, or, eventually looking towards stopping the medication. And so, this is something that's never been tested in people with rheumatic disease
Yeah.
who might be taking these drugs for many different reasons compared to the general public. And so, I'm interested to see whether this tool to review people's medications is useful for rheumatic disease patients, the way it's been demonstrated to be useful for other folks.
Right. So I want to be really clear with our audience that what I think you're talking about is helping reduce dosage, helping to actually take people off of medications where they just aren't needed anymore, but we get used to getting them filled. Personally, I've been a chronic disease patient for almost 37 years, and sometimes I'll get prescribed something for a short-term ailment. And then I get an automatic notice from the pharmacy saying it's been refilled, and I haven't asked for a refill.
Okay.
So
Yeah.
I don't want to say abuses, but there are things that happen that are really not in our control. So as a patient, you think, oh, I guess I better go pick it up. Do you know what I mean?
Hmm.
So that's where I see this being of huge value, this tool. But it's also important to note, people should never feel sort of medication shamed. If you're taking it, there's a reason
Hmm.
to take it. There's you are seeing benefit from taking it and it's been safe and effective in you. There's no issues with that. The thought of um, deprescribing my biologic actually frightens me because I know what happens when I don't take it. If I'm even a week out, I have a significant change in my disease activity. But anyway, all of that to say it's a balancing act. This piece about older people accumulating scripts over the years, I'm a classic example of that. I've been a patient for a long time, and when my pharmacist looks at the long list, we sometimes, like once a year, he'll go, okay, well, let's just see which of these are just old news. And we go through and get rid of
Yeah,
them.
that's really helpful. I wish everybody had a pharmacist like you.
Yeah. Well, we have a function, a billing code in British Columbia, which is where I live,
Oh,
and I'm a patient, and pharmacists get remunerated for conducting a med review. So this is where there is a money spend, but it's the benefit, the value for spending that money is huge, both in terms of my own safety and health, and also to the healthcare system for not just automatically filling and paying scripts and paying for the meds. So what a fascinating area of work that is. I could talk to you all day long, but I don't want to keep taking you away from your patients and certainly your scientific pursuit of excellence in your field, Dr. Mendel. So I'm super excited you took the time to sit with us as part of the hashtag C Arthritis event. I'm going to have you back in the studio and talk to you about a whole other pile of stuff if you want. Uh,
that's wonderful.
you're a font of knowledge, and we loved having you. Thank you again for coming in and talking to us about both your podium presentation and your poster and your colleagues' work. I understand now about the antinuclear antibody testing. So your expertise has been shared widely. I'm sure we'll have questions. If we can't answer them, we might be knocking on your email inbox and trying to get answers for folks who have watched.
All right, no problem.
Thank you so much, and you have a great rest of day and week, and we'll see you soon, I hope.
Very nice talking to you.
Thanks everyone for tuning in. Look forward to our next episode of the hashtag C Arthritis event. Bye for now.